everyone, and welcome back to the DBMI seminar series. Today's speaker is Dr. Daniel Prieto-Alhambra. He is a professor of pharmaco and device epidemiology at the University of Oxford Center for Statistics and Medicine in the Nutfield Department of Orthopedics, Rheumatology, and Musculoskeletal Sciences. His research involves using routinely collected health data to generate reliable evidence for improved patient care. Through an NIHR Senior Research Fellowship, he is investigating the use, safety, effectiveness, and cost of drugs and devices as used in usual practice conditions and amongst older people with complex health needs. He leads pharmaco and device epidemiology research at NDORMS and has experience designing, analyzing, and interpreting electronic medical records from around the world. He has worked on databases like the United Kingdom's CPRD, Spain's SIDIAP database, Denmark's Danish health registries, Italy's HSD, and Netherlands' IPCI. More recently, he joined the European Health Data and Evidence Network, EHDEN, and the Observational Health Data Science and Informatics, OHDSI, in an effort to accelerate and improve the quality of real-world evidence internationally. He also recently gave a talk at the OHDSI Annual Symposium's plenary session on some of his work. So today he'll be talking to us about OHDSI-EHDEN joint COVID-19 collaboration, global real-world data to fight COVID-19. So we'll do like 40-45 minutes and then Q&A. So with that, I'll hand it off to our speaker. Thanks for being with us.
Thank you so much. Yeah, I'm delighted to be here with you today. I'm gonna see if I can share my screen. Okay, I'll probably just share my presentation. You can now see my slides, right?
Yep.
Brilliant. Okay. Well, yeah, I would really wish I could be with you guys in New York and sharing this face-to-face, but hopefully some other time. I'm really looking forward to visiting. So this is the 5 topics or 5 bullet points that I am going to be discussing today. I'll start by giving you a little bit of a pledge for open science and why this is now more important than ever before, in my opinion. I will then cover very briefly the EHDEN OHDSI COVID-19 collaboration. I will then talk about unraveling COVID-19 and how the devil is in the detail when you come to phenotyping and describing this basically a new disease, and Matt was very much involved in that. Then I'll give you 3 examples of some studies we've done. The first one is a characterization study looking at people hospitalized with COVID-19. Second one is a drug utilization or a few drug utilization studies we have done or are in the process of finalizing. And finally, I'll tell you something we've done recently on the natural history of COVID-19 using multi-state models. Okay, so why global open science for a pandemic like this? So I'm sure that, like many of you, we started with a great and deep feeling of pride to be scientists at a time when people really need science to guide decisions. And then there was also a time when we felt pretty much the opposite, right? When these papers from the Sphere Collaborative were retracted, and when we realized that, you know, this is not only about data, this is not only about having access to a massive data set from who knows where around the world, but also about doing things in a very transparent, reproducible, and honest way. And I think the impact that these Sphere publications had was massive, and you know, it clearly went beyond what one would expect in normal circumstances, and I think this shows the importance of open science in a situation like the one we're going through currently. There is, I don't know how big this is in the US, but here in the UK and in Europe, the Data Saves Lives movement is very important. It, you know, it gives us a lot of thrust and a lot of energy to keep going and to keep working with different stakeholders to kind of battle the battles we need to fight. And it was very harmful for our entire field to see these 2 or 3 papers retracted. Interestingly, the papers retracted got actually through the whole entire peer review process and managed to publish in very big journals. whilst the only paper that was put in preprint was actually torn apart by people who were offering free and kind of pro bono peer review and feedback in a preprint server, and didn't ever make it into a proper publication, which I think should be a point for reflection also for the future. Now, this is a slide you've probably seen many times because it's courtesy of your head of department, and this is basically very strong evidence that in observational research, because of the lack of regulation that we have, and compared to clinical trials, and because of the easiness with which we can access data, sometimes there's been masses of p-hacking and evidence of poor practice that we need to address. Now, how can we help from OHDSI and from EHDEN and from all people involved in open science? I think the first thing is that we need to share all our artifacts of all our analytical pipelines, going all the way from the mapping of data and harmonization of data, data quality dashboards. We have to register our protocols, just like people do in the randomized clinical trials world. We have to share our analytical tools and analytical packages. We have to share our study diagnostics in a transparent and human readable way. And actually, this is one of the challenges that I think we have been encountering, that peer reviewers have not been used to navigating all these materials. And then the same finally with results. We need to report in full every single analysis that we do, no matter how many we do. And we need to be able to communicate this in a way that reviewers and editors will understand that. So I think transparency is the key to all of these issues, and we are going to need to be more transparent than ever to maximize reproducibility, interpretability, and trustworthiness in our field. So this is how one does this. This is just an example. We did this study starting from our study-a-thon that I will cover in a second. We registered our study protocol in the EU PASS register. This is just one of the existing registers hosted by the European Medicines Agency, so it's got some seriousness and professional component. We then published or made our phenotype definitions and analysis specifications public in an Atlas link that you can see there. We had a GitHub open where we had all our analytical code fully available to anybody that can run analysis on OMOP, on an OMOP data set. We posted our results in meta-archive, listened to feedback before sending for publication, and then implemented feedback into our finally submitted paper. This one went to Lancet Rheumatology in the end, and then we produced those an interactive application where you can see all our results in detail. So the EHDEN OHDSI COVID-19 collaboration. This all started with a study-a-thon, a virtual study-a-thon, an international activity that lasted for 4 days from March 26th to 29th, and that we hosted together with colleagues from Columbia, from Erasmus, and from other universities. The original plan was to have a meeting here in Oxford. We had place for more than 300, 350 people, where we would be talking science, learning from each other, and having some fun. And that, of course, all was cancelled, and we decided that the best thing we could do at the time was flatten the curve, and we had to postpone or at least cancel for now that meeting. And this is what resulted from those 4 days of collaboration. We had more than 350 participants, loads of meetings, loads of chats, loads of messages. I'm sure that some of you remember those very tiring but intensive 4 days with lots of discussion. We drafted 9 study protocols, which I think must be a world record probably. We released 13 study packages and designed, I don't know, hundreds of cohorts, and did what I think, is something we will never forget. So at the end of that, just to summarize what happened in those 4 days, we did 3 things that I think had never been done before. We did the first large-scale characterization of COVID in 3 continents. we finalized the first prediction model with external international validation on COVID patients to inform shielding and who should be protected against this disease. And we conducted the largest study ever done on the safety of hydroxychloroquine, which actually gave us a lot of insight and changed practice immediately. That study was put on preprint on the 6th of April, and a week and a half later, the European Medicines Agency issued a warning about the safety of hydroxychloroquine when used in combination with azithromycin. And I am also aware that many clinicians around the world changed practice and stopped prescribing those two treatments together. This is well like weeks before the recovery trial showed that hydroxychloroquine was also not effective to treat COVID-19. So the study-a-thon was a kickoff. It wasn't the final product. We thought, I'm sure at the beginning, that this would be an activity we would be working on for a few weeks, but there we go. We are now 7 months in and still this, we're just starting to ride the second wave. By now we have data, and this slide is like from a week ago, and it's now jumped from 4.5 million people tested to more than 7 million people tested now. More than 1.5 patients diagnosed or tested in the latest version that I've seen on the data set, and more than 250,000 people hospitalized with COVID-19 or for COVID-19. Data from North America, Europe, and Asia Pacific in what is, I believe, a unique collaboration and the largest data set in the world, or data network in the world on COVID-19. But we haven't finished. We are working very intensively in Europe, and I'm sure other colleagues are doing the same in other parts of the world. EHDEN is a European Commission funded project through the IMI initiative, where we are mapping data from different places around the world. And for this COVID-19 collaboration, there are 25 people that have been awarded grants to map their data to OMOB, including very interesting data like the Health Data Hub, which has access to the entire claims for the whole of France. So that's more than 66 million people. UK Biobank, which is a very deeply and richly phenotyped 500,000 people from the UK, and then data from places where we have never had access to data before, like the Istanbul University in Turkey. Okay, so now this is something that probably Matt would be better positioned to explain that myself, but I'm still gonna give it a go. So how did we go about unraveling this new condition? And I hope that we will never have to do something like this again. So the ideal definition that one would go for to identify COVID-19 in a real world data or routinely collected health data network like this would be, of course, clinically relevant. So it would be guided by clinical knowledge and by clinical decisions and what people are doing in the clinical settings. It should be actionable and interoperable for different types of data and different parts of the world. And that is more challenging than one would think. It should be transportable across a network of international data sources. It should be sensitive, and it should be specific. So you should be able to identify COVID-19 with little uncertainty. And then, of course, it should be possible or feasible, right? Because if you have all the above, but that is a dream, you will never make it. Now, what we ended up with is not one definition, but a few. One could go with an identification of cases based on test results. So you could say someone who has tested positive in a real-time PCR for SARS-CoV-2 has an infection with by COVID-19. You could go with clinical diagnosis. You could remind me how it went in New York, but I can tell you that in the UK and Spain during the first wave, we just didn't have enough capacity to test everybody. And we had many people, actually around 70%, 75% of people who got a diagnosis recorded in primary care or outpatient settings who never got tested. So there was a lot of clinical diagnosis without a test. We then could go for hospitalized with a recorded diagnosis, and that of course would probably give you a framework of the more severe forms of the disease. And even more severe, you could go for admitted in ICU in intensive care with a diagnosis, or of course you could go for death with COVID-19. And I'm sure you could add many other operational definitions in there, but this is what we ended up doing. So this is the cohorts that we ended defining that we will be going through very quickly. And each of the decisions we make when we define these cohorts, of course, has consequences, as you will see. So you can look for people who were tested for SARS-CoV-2. A subgroup of those would be the tested positive. A bigger group would comprise those with a clinical diagnosis or a positive test. Then you would have those that were hospitalized with a positive test. You can also have people hospitalized with a positive test or a diagnosis. And I would claim that that group probably is not as spread as you see it there. I think most people hospitalized with a diagnosis will be tested, and even in the first wave were tested. And then, of course, you can also have people requiring intensive services with a positive test or without a positive test, but with a clinical diagnosis in the worst case scenarios. Now, how does that work when you implement that in the data? So we had, and I'm only using a few example databases. I've chosen databases from different parts of the world and also from different types of data. So I'm showing here the data sources that you could have access to, or we had access to. We had hospital EMRs from your own institution, also nationwide US EHR, and HM is a Spanish database of just hospital EMRs, and that one is actually only hospital inpatient data. You can have claims data, and you have vast expertise with that, I'm sure, in the US. In Europe, we tend to use primary care databases because GPs, general practitioners, are gatekeepers to the system, and they are very good sources of information. And you can have ambulatory data like the IQVIA ambulatory data from France or Germany. So if you went for tested positive, you can see here what are the databases that you can where you can find test results, so you can identify this cohort. That would be basically 4 of all those databases. That would be 2 hospital EMRs and 2 primary care databases. You can go for diagnosed or tested positive, and that, of course, is the most comprehensive or the most the broadest of all possible definitions, where you incorporate any information from electronic medical records or diagnosis in claims and test results. And in here, that is when you get most of the cohorts, most of the databases contributing. You can see here how you have data from most of the databases that were available. You can go with hospitalized and with a test positive, and that will restrict your cohorts to only 3 databases in this particular example. So CPRD, for instance, doesn't have hospital admissions data even yet. They are working on mapping that data, but that hasn't happened yet. And if you went for hospitalized with a COVID diagnosis or a test positive, then again, that would increase the number of databases available. And in this case, you would include a quite large database like IQVIA Open Claims. If you then went for admitted to ICU with a COVID diagnosis or a test positive, then that would leave you with only 3 databases. Now, this is a kind of a similar thing, but now showing you the numbers that you get from each different data source, and you can see how there are many situations where different databases from across the world will just not work. And the most, let's say, the most generous, or the one that works for everyone, is the diagnosis or test positive definition. That's the one here, where you basically get all the data sources contributing to that definition. But of course, that might not be desirable in certain circumstances. I guess in the second wave, when we start doing research, we'll probably want to have a test positive because we will expect that most people will be diagnosed through a test. So what does that look like in terms of numbers? If you look at when I exported this data a couple of weeks ago, you have 4.5 million people tested in our network. Of them, 8.2% were tested positive, with, I must say, with loads of variability. So there are places where the test positive over tested was 2 out of 100, and others like Spain and New York, actually, where it was like 30% at the worst time of the pandemic. and then hospitalized with a test positive would be just over 28,000 people. So that's 7.7% of people tested positive. If you then look at clinical diagnosis or test positive, which we said is the broadest definition of the disease, you end up with almost 1.2 million people. If you then want to make sure that those people are hospitalized, that's about 20% of the people in the first cohort. If you then, and this is something we haven't discussed, if you then impose a certain look back, so you want to make sure that those patients have data visibility, they have been in the network or in the database before, that has a price. So in this case, that drops your numbers by about 25%. But I would claim that is actually quite important because that's the only way you can characterize people in terms of what they looked like and what happened to them before being admitted. And then if you looked at the just above, so hospitalized with a year look back and an ICU admission, that was at that time around 10%. So in summary, for this section, different phenotypes will provide different levels of confidence, depends on what you want, and will also reflect different levels of disease severity. So of course, diagnosed in outpatient is in principle less severe than hospitalized or ICU admitted, although even that, as you will see at the end of my presentation, is not always true because there were people, especially elderly people and nursing home residents who were not hospitalized and died without hospital admission in many places. These different definitions will accommodate different types of data and different geographical areas. And just a final note to say that this will change over time with increasing testing capacity and different patterns of community transmission. Okay, so with that, I think you now understand what we have been able to do with COVID-19 in the OHDSI and EHDEN networks. I'll start by showing you the first characterization study that we completed as part of the study-a-thon already. So this is something we finalized during the study-a-thon and was published recently. So what can we do with so much data? As always, with real-world data, we can do three things. Characterization, which is basically describing what happens to a group of people. Prediction, which is looking at being able to tease out what will happen to a particular individual based on his or her characteristics. And finally, estimation, which is looking at the causal effects of a given intervention in the population. All I'm going to be talking about today is just clinical characterization. And this is the paper that we've just got published in Nature Communications, deep phenotyping of 34,000 adult patients hospitalized with COVID-19 in an international network study. Just to give you a reminder, we again made our protocol and all the analytical code available. All the definitions of each of the different cohorts are available in Atlas. We posted our manuscript on medRxiv in early April, and all our results are available in a Shiny app. For this particular study, we had data from 3 continents, from North America, more than 8,000 patients, Asia, more than 7,300 patients, and from Europe, in this case only Spain, more than 18,000 patients. And we chose influenza as a benchmark. So we looked at people who had been hospitalized with influenza in the past as a benchmark and as controls, if you like. And we extracted thousands of features from all these patients and summarized them in an interactive web app, as I said. Interestingly, we learned very early on that COVID-19, let's say more severe forms of COVID-19, so this is hospital admissions for COVID-19, is more common amongst male populations in most data sources, and the only exception here was Hira in South Korea, and there are reasons for that. There was an outbreak related to some religious cult that apparently drove the distribution in that direction. Age profiles varied across the data network, and I would say that overall what we saw is that compared to influenza 2014-2019, there are more admissions for COVID-19 in younger populations, although of course most of the admissions happen in the oldest patients. this is an interesting plot that depicts basically the prevalence of all the conditions and use of all the medicines recorded in the patient record in all the contributing data sources in negative. So that would be in the bottom part of each of these plots. What you see is things that were more common in people admitted with the flu than in people admitted with COVID-19. Anything above the gray bar would be things that are more common in COVID-19 than in the flu. And in summary, what you can see very quickly from this plot, and what you can learn very quickly, is that patients with COVID and flu who were admitted to hospitals don't look so much as each other as we thought at the beginning. Patients admitted with COVID tend to be healthier. You can see that there are many more points below than above the gray line. They have less use of medicines. And there are a few exceptions that are quite interesting, and I think we haven't still completely figured out, but I think we understand now, which are obesity, diabetes, and probably related to the two previous osteoarthritis. There's an interactive app that I don't have time to go through, but where we have all the findings, and you can look at the characterization of the different cohorts and even compare different cohorts to each other to learn how patients differ. If you look at people hospitalized with the flu, with people hospitalized with COVID-19, or people diagnosed versus people hospitalized. The second characterization study I'm going to be showing you now is a drug utilization study. As you probably can imagine, and I don't know how many of you are clinicians, we don't encounter a new disease every day, and we don't need to suddenly present ourselves in A&E making decisions on how to treat a condition without having any clue whatsoever what we should be doing. So you can imagine, before I show you the data already, that there's going to be a lot of improvisation, a lot of variability in the use of medicines, and I don't want to get into the politics and all the media coverage of different medicines that were proposed at the beginning of this pandemic. But it's beautiful to see what happens in the data when you then explore that in retrospect. So basically what we were interested to do here is look at patients diagnosed with COVID-19, or in this particular study that I'm going to show you, I'm going to be focusing on people hospitalized with COVID-19, and then we looked at the use of medicines in the previous year, in the previous month, on the index date, and then on the following month after their hospital admission date. This is the first picture, which is drug utilization in the 30 days after admission with COVID-19. And this one focuses on antiviral and repurposed therapies. Different colors are different data sources, and the one that you see there in purple is data from a hospital in China, a chain of hospitals. I think it's 9 hospitals in China. The one in blue would be HIRA, which is South Korea. Orange is HM hospitals from Spain. The one in green, lime green, is Columbia University. And so on and so forth. I guess VA is the Veteran Affairs, which you'll see has a different pattern. And then what you see as a rectangle, as a triangle, is is the use of medicines in the month after being admitted in ICU, and the circle is the use of medicines in the month after being admitted to hospital. And it's fascinating to see how medicines have been used with a lot of variability, and I think for many reasons, hydroxychloroquine is a good example of that, and you can see how much variability there's been in the use of that drug. And then also interestingly, you can see how, for instance, in China, which is the country that was, of course, hit first by this condition, there was a lot of use of medicines that we have never used in Europe or North America, including umifenobir, that I don't think that even exists in Europe, or ribavirin, which we haven't used in any of the contributing data sources. And then interestingly also, you can see the use of lopinavir, ritonavir, which was quite substantial in some places like in Spain and South Korea, and not so much in other places. This is for treatments that have allegedly have some antiviral activity. Now, the second group of treatments, of course, is the concomitant or adjunctive treatments, and these are treatments that were used to prevent or to treat complications from the disease. And you can see that the first 2 most common were anticoagulants, enoxaparin, and corticosteroids. Now we know that corticosteroids have a role to play in the management of this condition, of course, but I don't think there was so much evidence when we started collecting data. And you can see how there was a lot of variability in the use of corticosteroids, which is the second line here. I would claim that some knowledge from the SARS epidemic 20 years ago meant that colleagues from South Korea were not very keen to give corticosteroids, because in the treatment of that condition, it was said that corticosteroids were actually the opposite to helpful. And then you see also a lot of use of statins, ceftriaxone, aspirin. Vitamin D, interestingly, was heavily used by some colleagues. Famotidine. Alpha-1 blockers are an interesting group of treatments that have been preconized to have some immune-based activity against this virus, and were interestingly initiated. Vitamin C, dexamethasone, ACE inhibitors. So you can see there's a lot of experimentation. I'm pretty sure that the anticoagulants, antithrombotics, and corticosteroids were used to treat given symptoms, but many other treatments like alpha blockers, who knows? I mean, those are treatments that we use for VPH, right? So how would you start that for a patient hospitalized with COVID-19 other than out of desperation? So that's quite an interesting observation, I think. And this, of course, is the rise and fall of hydroxychloroquine that I'm sure Matt will be glad to see in the data. So hydroxychloroquine, for many reasons, rised in use to a point where, I haven't said, but I work in a rheumatology clinic, and my rheumatological patients were struggling to find it because people were just, emptying the pharmacies for many potential indications, including prophylaxis. And you can see how that went up very rapidly in February and March. We published, this keeps jumping out. So we published our paper, or we posted our paper in April, and then already in May, you can see a massive drop in the use of that medicine. And then by, I think it's late May, that the recovery trial found that that treatment was not effective. So we, I guess, contributed to providing evidence that changed practice here, and to change practice in the best direction and in the interest of patients. Now, this type of large data sets gives us an opportunity to also explore things that cannot be explored elsewhere. And we stratified our data by different cuts. And I'm going to be showing you very quickly data from pregnant women and children and adolescents with hospitalized with COVID-19. You can see here a cohort of over 2,000 pregnant women admitted with COVID-19. And you can see a lot of use of corticosteroids, antithrombotics, antibiotics, and vitamins, and not so much use of any other things. So you can imagine that experimenting on pregnant women is a little bit scarier, and people didn't really give it a go when it came to giving them, things that were probably not so easy to prescribe. There are still some alpha-1 blockers that are, I would say, a little bit, I guess the people prescribing that could be interviewed at some point. But so corticosteroids and antithrombotics and antibiotics are used all the time in pregnant women. So you cannot really say that there's masses of concern in terms of safety. Maybe, of course, in terms of efficacy, but not so much safety. And this is children. Children, of course, are again another population that we are usually very careful when we treat. And you can see how antivirals were not very much used. There's a little bit of use of lopinavir, ritonavir, and some hydroxychloroquine treatments that are used for other indications, of course, but have been used routinely in children. And then you can see quite a bit of systemic steroids, which again, we use for things like asthma exacerbations, some famotidine, and then maybe more interestingly, some antithrombotics, including heparins. This is the link where you can find all the data that I'm going to be showing you next, which is now not the population level drug utilization. So not so much the incidence or prevalence of use of medicines, but now at the patient level. So this is characterizing uses of a given medicine or a given treatment in people with COVID-19. You can see in this app how you can characterize groups of people based on the cohort that you choose. So this is now outpatient diagnosis of COVID-19, and I'm focusing on demographics, and the treatment I'm looking at is ACE inhibitors in CDAP. I'm just showing you so you can play with this in the future on your own. You can look at the treatment initiated or new drug users of any given treatment in outpatient, inpatient, or intensive services. You can compare cohorts or characterize cohorts across data sources. So this, for instance, here is inpatient use of dexamethasone in a number of different data sources. You can only see two in this screenshot. And you can also compare cohorts, and this is now, for instance, looking at inpatient initiation versus post-ICU initiation of dexamethasone in a particular database. And if you look at that in a kind of more visual way, this is a plot or 4 plots looking at the baseline characteristics. So this would be the month or the year before initiation of these treatments in HM, which is hospital data from Spain, on the left of your screen, and then the same comparisons on Optum EHR on the right. By the way, somebody has to fix that correction of EHR to HER. It happens to me all the time, and there's no way I can realize when it happens. So yeah, you can see here how dexamethasone initiation is given typically to people with more comorbidity and more drug usage than prednisolone, and that happens interestingly in both databases from 2 very different parts of the world. And the same would be true if you compare tocilizumab to prednisolone. So, and that's even clearer in the US data there. So you can see how tocilizumab is given to people with more comorbidity or a more complex medical history than prednisolone. I think that is quite interesting. And of course, in the studies that we're going to be doing next, which are going to be comparing the effects of these treatments, that is going to be a challenge because that is the perfect definition of confounding by indication. Okay, finally, I'd like to finish my talk with a brief talk on the natural history of COVID-19. We've used, and this is something we're still experimenting with, but I'm delighted to share it with you guys. We are looking at trying to define the different transitions that people go through in this condition. We have the luxury in Spain to have a universal taxpayer-funded healthcare system, which means that anybody, the minute you land in, let's say, Barcelona, just to name a beautiful city where I was raised, you get healthcare, and you can just go and get whatever treatment you need. And that also means that everybody is registered in a kind of general population registry, and everybody is able to access healthcare in primary care or hospitals. And finally, just like in the UK, you can only access hospital care through a primary care referral or through A&E. So that gives you, I guess you can imagine, that gives you the perfect kind of ecosystem to explore the natural history of a condition like COVID-19, where many people, especially young people, don't really need a hospital admission. What you can see in here is the different transitions that people can go through, going from general population to a primary care diagnosis, going from general population to a hospital diagnosis without going through primary care. So those 8,000 and something would be the people that went to A&E and got admitted. You can, of course, die from other reasons, right? So that's the 11,000 here. And you can die after a primary care diagnosis without going through hospital or after a hospital admission. The total size of the data set is 5.6, more than 5.6 million people, which is about 80% of the population of the region. And the data that we have here and we've used includes all the central lab tests, hospital admissions data, and mortality registry data. Now, with that in mind, what we are going to do then is look at the effect of age and sex on each of the different transitions from population to diagnosis, diagnosis to hospital admission, and then to death. What you can see very quickly, and is kind of as expected, is that most of the outpatient diagnosis happened in middle-aged people, and there's an overrepresentation of people 50 plus in the hospital admission database or in the hospital admission cohort. And most of the deaths, if you focus on the distribution in the mortality pyramid, most of the deaths happen in people ages 65 plus. If you then look at the effect of age on the different transitions, this on the top left is the transition from general population to being diagnosed in an outpatient setting, which is the usual way in a healthcare system like this. You see that there is a peak here, which is around 40 to 50, 55 years old. That's where most of the diagnosis happened. But then there is also a lot of diagnosis in the elderly people that will be above 65. And then if you look at how many people got admitted to hospital with COVID-19 without going through a primary care physician, that basically happened in the elderly people, right? So the younger people went to primary care first, and then if needed, got referred to hospital. The older people and sicker people went straight to hospital. If you then look at from diagnosis to hospitalization, that is something that we saw most commonly in these people between 50 and 65 years old. If you then look at the association between age and the transition that goes from diagnosis in primary care to death, that is something that pretty much only happened in 75 plus. And that's the typical population that would be considered not fit to be admitted to hospital for the treatment of COVID-19 and unfortunately died in nursing homes and so on. And then mortality in hospital, so going from admitted to dying, that happened also in the 75 plus. Sex, I think, is quite interesting, and we are now learning this or relearning this in the second wave. We know that men have a higher risk of almost all the transitions with only one exception, and that is infection or primary infection. So women are more likely, or were at least in this data set, more likely to get diagnosed in an outpatient setting than men. But of course, the more severe forms of disease and the more severe transitions, or transitions that go that are equivalent to worsening, happened most often in men than women. There's a meta-archive of this, and the paper is now undergoing a second round of reviews at Nature Communications as well. Okay, I'm going to finish here, and I want to thank everybody that contributed to the studies. And I think we have quite a few pictures from people with different backgrounds living in different parts of the world, and some of them smiling, some of them suffering some sort of shock when being taken a picture. And I mean, we didn't even have space in this big slide to have everybody's picture, but you have their names there. And this is, I feel honored to be presenting this today, but of course I am not the one who has done this work. This is just a massive global team effort. Thank you, and I think we still have more than 15 minutes for questions.
Yeah, thanks for the talk. It was really interesting, important work, and I think we'll take questions now. So if you want to use the raise hands feature on Zoom, we can take questions that way.
Well, Daniel, excellent talk. Thank you so much. I'll jump in with a question here. Hi, this is Sarah Rossetti. I'm wondering, we know the reasons, of course, for the need for this rapid work, at this level, at this scale, which is so impressive. What do you think, are there new processes or lessons learned that could be applied to other areas within healthcare where we could, kind of re-engineer how we conduct some aspects of our research? I'm just wondering what you think about that moving forward, perhaps once we have a chance to breathe after, hopefully, the COVID pandemic begins to resolve.
Yeah, that's an excellent question, Sarah. So yeah, I guess I would say one of the key things is that there has been a level of collaboration and willingness to help that is unprecedented. So we managed to have approvals for protocols in places like, in the UK, CPRD, we have this committee called ISAC that typically takes about a month to review an application, and we got this one approved within a week. And the same was true for CDAP and many other data custodians. So I think there's been things that have been eased to facilitate research into COVID-19 that I don't see a reason for restricting or making hard again. then I also believe, to be honest, that I don't think the level and amount of work that some people were putting in is sustainable over time. I don't think we can do this for all conditions and and forever. I think this is quite a unique situation that people rallied together to work against the clock and contribute to something that was felt to be urgent and important. Other things that I think have improved include the communication with important stakeholders. So I think there has been, in the US, of course, the FDA has been chairing an evidence accelerator. The EMA has created a database. Sorry, the EMA would be the European Medicines Agency, has created a similar framework for people to provide evidence. And I guess, those mechanisms should continue to exist. And you could say that they have proven more effective and more reliable than the usual kind of scientific publications, which you could say is where most of the worst things have happened, right? So the papers that have been retracted were not retracted from an archive; they were retracted from the New England Journal of Medicine and the Lancet. So that is something that we also need to review and see how we change that for the future.
Danny, hi.
Hi, Josh.
Hey, and sorry to come in late because of the other meeting I told you about. Can you talk a little bit about the role of characterization and how it's changed over like in March, it had one purpose, and now and then the future? Like, are we going to be done with characterization, or do we keep doing characterization?
Yeah, that's a very interesting question. So characterization is probably the Cinderella of all the research we do, right? So it's the less sexy component of everything we do. Nobody wants, nobody goes to Columbia or to Oxford to learn how to do a characterization study, and that is unfortunate. But I think characterization has been extremely important in this particular example because it was a completely new disease, right? So we needed to understand what it was all about, who was it affecting, and so on and so forth. I think characterization is probably the first milestone to everything else we do. Without a good characterization study, you cannot do prediction, you cannot do causal estimation. So I think it's always important, but for this pandemic, it has proven even more important, of course, because there are many things that we still need to learn. I think what we are going to be likely to learn in the coming new months will be that characterization continues to be important, because I think we're going to have different ways of identifying this disease, including serological tests now. I don't know if you're using them in New York, but they're becoming a big thing in the UK and in Spain, and probably in a few weeks' time we will also be using other types of tests, and those will lead to different phenotypes and probably to the identification of many more asymptomatic people. So I think we are going to keep needing a lot of characterization studies for this condition.
Hey Danny, it's Naomi. Thanks for your talk. I was also wondering about the future and of characterization in the context of COVID, and thinking about like what would you need to change anything in the protocol if say you wanted to characterize like long haulers versus like the first wave of knowledge that we got about COVID, which was in hospitalization and ventilation and this type of like acute things.
Yeah, that's an excellent question, Naomi. So I think long COVID is definitely going to be something important. There's so many people complaining of symptoms. Unfortunately, I think the main challenge with that is that there is such a big wide chunk of the population likely affected by this condition in the first wave that never got tested. So who knows? I've been doing some work with colleagues from Georgia, looking at tweets and reviewing Twitters, and it's very tricky to know whether those people really had COVID-19 or whether they have a completely different disease, because of course there's been a massive impact on mental health as well. So I think we're going to need to make sure that we identify people who had COVID and then make sure that we characterize long COVID very well, so that we don't mix it with other conditions that are more related with, mental health problems and the likes, which are similarly important, but of course might need a completely different treatment.
I mean, one clarification, when you showed both the CHARYBDIS characterization and the SCILA characterization. And you expressed it as like, well, one's looking at individual, but really the difference is what? The difference is one is designed to look specifically at the research questions you want to test hypotheses on to see if you can do that hypothesis test, and the other is just for general characterization. Like, should we be using, like, what is the use of the SCILA characterization other than deciding whether to test hypothesis? I guess that's the question.
Yeah, so I think, so we do quite a bit of, and I think that's probably the type of characterization that we do the most in pharmacoepidemiology. So we do all the time, we keep doing these drug utilization studies where you want to know two things, right? One is the uptake of a given medicine in the general population, and that would be similar to the CHARYBDIS characterization, where you anchor within a cohort of people with a disease and then look at what treatments they received. But regulators and many stakeholders and clinicians are interested also to know the baseline characteristics of the people who start a given medicine, so that you can, of course, assess whether those people had the indication that they should be having, or whether it's an off-label use of a medicine, or whether there was any prevalent contraindication. So I think that is what we can get from the SCILA characterization, where we can see exactly for a given group of people, what were they like before they started the treatment. We are nesting this within a cohort of COVID-19, so we are not doing it the typical way in drug utilization studies in the general population, but still that's, I think, the main learning we get from there is the baseline characteristics of people who start taking specific medicines.
Okay.
Do we have any other questions? I think maybe we can close a little early if there aren't any other questions. So.
Yeah, well, thank you so much, Daniel.
Thank you, everyone. It's been a pleasure.
Yeah, thank you.
Presentation. This was really, really great.
Thank you, everyone.
Yeah, thank you so much.
Thanks.
Yeah, I'm really hoping I will come to visit you sometime in person, guys. That will mean many positive things.
Hopefully sooner rather than later.
Thank you, everyone. Bye now.
Thanks. Bye-bye.